these before. At the same time, though, I don't really feel that bad about repeating it because of the stuff that we're talking about here. I am still, to this day, having guys telling me that they've been after their prostate cancer treatment, surgery, radiation, whichever, and these things, which are, I think, all very straightforward and everybody should know, um, are still being, guys are still being surprised that these things exist. These options exist, that treatments exist, and there's things that can be done. Uh, I think a small part of me wants to vow to continue to keep presenting at least some part of this again and again and again until I no longer have guys being surprised that there's ways of treating these things after prostate cancer treatments. Anyways, so we're going to go through a couple of things here. And again, for those who have attended some of these, I apologize because there will be some repetition. So first off, an important part that I always like to emphasize is whenever we're talking about cancer treatment, I think it's under discussed very often, is the concept of survivorship. Particularly, and those who've been through the treatments may be able to support or deny this thought this impression that I get. But many times it does feel like when the cancer center has a hold of you and they're helping you through something, it sometimes feels like they're treating the cancer more than they're treating you. And the whole concept of survivorship is that you're really trying to emphasize the patient's quality of life, and what are their outcome goals that they're looking for while you're still managing the cancer, and even after you've completed managing the cancer. So you're trying to restore as much as you can of that particular fellow or woman, depending on what kind of cancers we're talking about. Understanding that complications of therapies are going to be present, and they're going to be there for many years. And sometimes what complications we are entertaining, depending on what procedure or surgery or treatment we're going to do, might change somebody's mind, especially when you have equivalent outcomes. So if you have two treatments that are going to be just as effective with each other, sometimes you're deciding more what side effects and complications you want rather than what treatment you want. And rephrasing it that way sometimes can help some folks figure out how they want to move forward. And I think an important part that, and again, this is sort of my own criticism of the many cancer centers, this is not just Saskatchewan, this is basically every cancer center I've ever been part of, is that we really do fail on showing folks how to try and reintegrate to normal lives after cancer therapy. You think about those who've gone through cancer journeys, there's this very strong narrative of, we're in this together, we're going to fight this cancer together. It's a very, creating and conditioning a warrior style of an approach. We're gonna push through this very tough battle. But then once you're on the other side of it, it's they're kind of give you the high five, or you get the ring the bell and the chemotherapy speech or whatever, and off you go be normal again. And who knows how to do that? Even using that warrior analogy, we send some young people off to war, and they have an entire decompression protocol about how they can reintegrate into normal life. We understand that it's a different mindset, but we don't do this for cancer, and quite honestly, we really should. So I'm going to get off my soapbox now. We're going to talk about some data and the major issues that we have when it comes to post-prostatectomy, post-prostate cancer radiation. Options are around the penis. So we got erectile dysfunctions, one, and then of course there's some other concerns, and the pelvis, which is incontinence. So in terms of erectile dysfunction, quite bluntly described, it's just difficulty or inability to achieve and maintain an erection sufficient for penetrative sex or intercourse. How common is this? Well, it's excessively common outside of any discussion around prostate cancer. I'm just talking about in general. The easy numbers to remember is whatever is your age, put a percentage number behind it. That's how many guys in your age group have some erectile dysfunction. So yes, that's about 40% of 40-year-olds. And what's even a bit shocking by that is about 5% of those 40-year-olds have zero function. So complete impotence or complete erectile dysfunction. If you kind of think about how many 40-year-olds you see sort of walking around, if you've seen 20, one of them has nothing going on, not even a little flicker. So probably the biggest reason I like to bring these stats up is to really emphasize that if you don't have erectile dysfunction, you are in the minority most of the time. It really is the expectation that everybody does, particularly as we kind of get into the older age groups. And it's common. And every guy, though, does really feel like they're an island when they have it. It feels very isolating, like they're the only one. And it's mostly because we've all been conditioned to never say anything except how we are the be all and end all of penis and sexual virility, and that's been bred into us since we were teenagers. When we promptly wrote it on the side of bathroom walls. But that idea is that we are not allowed to express that. And the reality is that that is the norm. That is the accepted okay. There's lots of different causes for erectile dysfunction. Psychological, there's nerve related after cancer treatment, for example, hormone related, anatomy related, and blood flow related. And I often kind of like to harp on this again, and this is again outside of the prostate cancer discussion in general. Erectile dysfunction is really important because it is an early marker of a lot of heart and blood vessel disease. The arteries that go to the penis and the ones that go to the heart are almost the same size. In fact, the ones to the penis are a little smaller. So what that means is that you can see some changes in your function in your penis before you're going to notice any changes happening with your heart. It gives you an opportunity to intervene, maybe change something. So the man's penis and function is important. Changes are often noticed but ignored. And then we have predicted with some studies, if guys are honest about it, and they do notice some of the symptoms coming on, they're probably going to be able to predict if they're going to have an event, if they do nothing, and if they're going to have a cardiovascular event of some sort by about 2 to 5 years from when they onset of first having some symptoms. So it's a great opportunity to try and intervene. And we often will talk about erectile dysfunction as the canary in the coal mine for so much heart, blood vessel, even stroke related diseases, because it's all down to blood vessels. And, the penis is just a fancy blood vessel that we can use to have some fun. That's all it is. And if it's not working as well, that means everything else is not working as well as well. So, good, it's important. So why bother treating it? Well, because it's fun. That's the first easy answer. But also, and let's be honest here, most relationships are forged with a component of sexuality at its base. Now, that doesn't mean it has to be there, but it's allowed to be important, maybe is a better way of describing it. So it's not necessarily, it doesn't have to be the natural pathway for you as a couple that you move towards an asexual relationship. If you choose to do so, that is 100% your decision as a couple. There's no criticism there, but it should be your choice, not something that was thrust upon you. And so that's why I often will say, if you as a couple, socially, relationship wise, whatever reason, decide that you're no longer going to be wanting to engage in sexual activity, that's fine. There's no issue with that. But I only have a problem with it when you are doing it because your body's not letting you, as compared to you just choosing not to. Those are two very different situations. So if biology is holding you back, then it's my problem. If it's just you not wanting to do that anymore, well, that's perfectly fine. Now there's this questionnaire that has been developed. It's called the SF-36. It's a bit of a weird, complex questionnaire, but it's a really general one that you can kind of almost put a number to how much and how important the benefit or the negative of having a problem or not having a problem is. It's a bit more complicated than that, but the easiest way of thinking about it is that it's roughly kind of a number out of 100 about how happy or how good somebody is when they have something or don't have something. So if you just think of it as a number out of 100, when somebody has erectile dysfunction, sort of the impact that's having on their general quality of life, it's like a 43 out of 100. But if they're treated, it's like a 74. So what you're saying is that you are improving that person's overall quality of life by treating their erectile dysfunction. So it's a again, it's a little bit more complex than that, but that's just an easy way of sort of thinking of it and just sort of proving that we do have some of these questionnaires that can really hammer this down for us. That you're not just you are genuinely improving overall quality of life by treating the sexual aspect of these people. And again, not just important to men. This is looking at what are some quality of life scores that were being compared. Again, different age groups. You can see the different colors there on the right hand side, and looking at the different age groups and seeing, hey, there really is some changes here in the control group. That means the group that doesn't have sexual dysfunctions, and the ED group, those who have erectile dysfunction. So there's a difference. And again, these are the partners of those men, not necessarily the men themselves. So how do we investigate it? Well, the easy stuff is a history physical examination. That's the kind of the basic stuff that we do. We do some blood work. As part of my blood work workup, I like to always make sure that we have a cardiac profile and looking at your blood vessels and your hearts, just because, like I said, there's huge overlap. So if you're already coming to me for some degree of the erections not working, then I think it's likely that there's might be some early disease somewhere else. And while I can work on getting those erections up and running again, it's even more important to me if I can catch it early enough that you don't have that heart attack, and we can get you in combination in communication with the cardiologist to get you sorted out. That would be even better. We do like to screen for diabetes and cholesterol problems too, and I look at the hormones as well. And then imaging, this is specialized imaging that I do. I don't think you have that available in Regina, but I definitely I do it in Swift Current. It's a kind of a vascular uh, very active ultrasound of the penis that actually allows me not only to see the blood vessels going in and out, but actually see how they change because we give you a little bit of a medication that actually opens them up, gives you a little bit of an erection too. But it really also then allows me to also look at the penis because sometimes we can get some surprises, particularly in guys who've had treatments where whether it be surgery, radiation, or whatnot, that they went in, they had their treatment, they, were struggling with their erections, they didn't really come back. And then I gave them a bit of an erection with the medication, and lo and behold, now their penis is curving. And that can happen. It's uncommon, but it definitely does happen. Different disease called Peyronie's disease can take hold. So it's a new problem. And the guy had no idea because he didn't have erections anymore. But now that I gave him one, well, now we have a new problem that we have to deal with. So how do we treat it? Well, there's certainly the medications that I'm sure everybody has at least heard of. The Viagra is probably the most famous. Cialis is another great one. You probably haven't come across Levitra very much. It kind of fallen a little bit out of favor. Um, it's not like it's bad or anything. We just don't use it nearly as much for a few reasons. Now, one of the oldest methods of treating erectile dysfunction is using the vacuum pumps, and that's what we have shown here. So this is basically a penis pump. It's what's nice about it is that it's medication free and it's reusable. It doesn't interact with anything. It's easy. What's not great about it is that it's only erect to the base of the penis. And you see those little rings there, those fit over the device and then they snap shut over top of the base of the penis to keep the blood in it. The penis is mostly drawing in venous blood. So some partners even will sort of notice it kind of, one feels a little bit colder, or two, even has a little bit of a blue hue to it. Not everybody notices that, but some do notice that difference. And the penis, although it's erect, it's not standing up against gravity because it's only erect to the point of the ring. So if you do pull out, it'll flop down. You have to reposition it to get it back in. It's mostly just very uncomfortable, and if that ring is tight enough for you to trap the blood inside the penis, it's pretty darn tight, and that usually is the biggest rate limiting factor, is that it's uncomfortable. Now, there is a little medication that we can actually put directly inside the urethra, and it's like a suppository, basically. And you put it inside, you massage the penis for about 20 minutes, and it kind of allows it to slowly absorb. And it's the same medication that I give as an injection, just gets absorbed that way instead. Generally speaking, it can work. It just ends up being a little pricey, and it also has a because of that applicator, not all guys are really good at using it. So some guys will kind of scratch the inside, so that you get some stinging and burning when you pee afterwards, and also a little bit of an uncomfortable sort of throbbing pain that can last for a while afterwards too. So not super popular, but it was a nice, interesting way to try and deliver the medication. Like I had mentioned, you can do injections. That sort of is a mainstay. It sounds intimidating when you first mention to a guy, "Hey, we're going to teach you how to inject your penis." The reality is the needles we're using are so tiny. It just feels like a pinch. And once you get past the mental roadblock of you're putting a needle in your penis, once you're past that, then it's really easy. Guys like it because it tends to be super responsive and super reliable. You put Once you figure out your dose, you put that amount in, it's going to work. It takes about 5 minutes, and then you're ready to rock. Very simple. So, and it's of all the different methods I've mentioned, it's actually the most cost-effective one in terms of actually getting things done. And then last but not least are the penile implants. These are now in insured covered services after having your prostate treated or removed in some fashion. It is basically those two cylinders would sit in on the inside of the penis on either side, which would normally be filled with blood. You have the reservoir, which is tucked away, hidden, kind of next to your bladder where you can't feel it. And that pump is sitting down in your scrotum like a third testicle. And the idea is that when you're interested in having sex, you find that pump very easy to find in the scrotum. You start giving it some pushes. It takes about 6 to 10 pushes for it to inflate all the way. And then you have good rigidity. You can have sex for as long as you like. And then you hit a different button to deflate it. So it's an extremely good option, and it's kind of one of the reasons, because we have that implant, why I can so boldly say that there is almost no way and no reason why we can't make an erection happen. There's always exceptions, but just about everybody we can get working one way or another. So, medications, like I said, there's the phosphodiesterase 5 inhibitors. That's the name of the class. These were completely accidental in their discovery. They were actually trying to find an alternative to the nitroglycerin patch and nitroglycerin sprays. That's what they were trying to do. And what they found out is that all of the guys who were as part of the study were refusing to give their medications back. They had to figure out why. So this basically just turns up the volume of the pro-erectile signal. And that's really what it does. So this is why it really doesn't work after a lot of prostate cancer treatments, because most of those treatments, they damage the nerves. So if the nerves are not transmitting, they're not sending a signal anymore. If you're turning up the volume on a dead radio, it doesn't do anything. And that's kind of what happens with some of these medications. It's also kind of why they tend to really not work very well after you've had either treatment. Now, there's some slight differences in terms of time and effect and how long it stays in your body for between the medications. And then they all can react dangerously to other nitrites, such as if you do have a nitrile spray or a nitrile patch. So those are definitely contraindicated. You don't want to mix those. That's just a very funny advertisement that they had out there. Not a real one. Somebody just photoshopped that one, but it's just too funny not to include. And again, here's all those different medications. I did put one other on here called Avanafil or Stendra. That's only available in the US. And the real ones to kind of pay attention to are Viagra and Cialis, or sildenafil and tadalafil, the first and third ones. The main reasons for those is that you'll notice that the Viagra in Canada is the one that has the quickest onset and gets out of your body the quickest too. That can be really important for some guys who might need to be taking some of that nitroglycerin from time to time. They want something that's going to be in their system and out fairly quickly. So that might be a really good reason to go and use the Viagra. It is a little bit sensitive to food and what's in your stomach. So you can screw up how much you absorb of it by having particularly a fatty meal right before taking it. The Cialis happily has absolutely no effect on what meal you've had. You can chug it while, plowing through some big thing of poutine and pierogies. It doesn't matter. The thing about it is it does take a couple of hours at least, sometimes longer, before it really gets in your system to do anything. It has a very slow ramp up, if you will. And then once it is there, it does stay, however, in your system for a good 38 to 40 hours. Now you're not walking around with an erection for 40 hours. It means it's turned the volume up. So if there is no signal going through, nothing's happening. You take a Cialis and you watch a baseball game, nothing's going to happen. But if the opportunity presents itself, then you have a stronger reaction than you would have had on your own. So the vacuum device, just like I kind of described, it is again negative pressure, does the suction. Again, there's that tight band that you see at the base of the penis. And that's in that case, it's looking like it's just sort of standing up against gravity. That's not really what would happen. Once you have it secured like that, it'll probably flop to the side. It would be erect, but it doesn't stand up like you'd expect it to. That's that urethral suppository. Again, it's called Muse for those who've heard of it or are interested in it. It does take a little while, but again, penile pain, what we call urinary frequency, those can be a little bit of a concern that we sometimes worry about. Uh, Again, this is the injection, like I mentioned before. There is a whole bunch of customized medications and recipes that we use for this just to really make sure that this all works and it works well and works well together. And sometimes I've even, I have about a dozen or more standard concoctions and mixes that I use. And still every couple of months, I'm having to call up the pharmacy and we have to create a new one because this one is just not working and we got to figure out what's going to work out for this guy. And so there's some guys out there who have very truly customized medications that really are just for them, just because of a little bit of back and forth and figuring out what works. Again, intracavernosal injection or ICI, it's very easy to do, easy to perform. You basically get to bypass about 3/4 of all the problems that could lead to erectile problems. It just becomes a vascular issue, and that's about it. It bypasses everything else, which is great. And it can usually compensate for a lot of anatomical or vascular problems even as well, because you can just crank the dose up until you make it work. You do have to keep the solution cold. We have to get it from a compounding pharmacy because it is made from scratch. It does require some needles and very rarely cause some scar tissue with it. Most of the time, it just goes swimmingly and guys are happy. And then, like I said, there's penile implants. The penile implant field, there's a duopoly, although there is look like a third person who's trying to, third company that's trying to wedge their way in. They haven't really got to Canada yet, but these first two companies are AMS Boston Scientific is one and Coloplast is the other. Those are the two main companies that we get these devices from. They're all excellent devices. They have malleable rods. This is basically, think of them like a fancy pipe cleaner. Basically, you bend it up, you bend it down. Very simple. They are kind of like a permanent semi, though. You don't really have that really good stretch, that really pleasurable feeling of that stretch on there with that. It is just a permanent semi. The hydraulic systems, that's where you get that nice fullness and stretch within the penis. Now, both of these are surgical procedures. Most devices are going to last 12 plus years or longer. So I often will joke that the device is going to last longer than the guy will, and not to worry about it. The biggest concerns are infection and erosion. We want to make sure we put it in cleanly. We want to make sure we don't have too much pressure on any of the parts. Some guys do note that they feel like they might have a bit of length loss, and it's kind of both correct and not at the same time. If you look really closely at that diagram on the bottom right there, you can see that the device is sitting in there quite nicely, but it ends just as it's entering into the penis. I'm not sure if you can see my cursor, but it ends right about here. It doesn't actually fill the whole head of the penis. That means that the head of the penis is actually not swelling with the inflation of the device. And normally, if it did swell, you would have a little bit of some additional length and girth, right, particularly at the tip. So that does actually get lost. It's still there, it's just not being swollen up. And the standard are what we call the three-piece inflatables. The one company is the AMS 700, has what's called a conceal reservoir. These are sort of like a flat reservoir to hold it, so it's really tough to even feel that it's there. They put their antibiotics into the device to really minimize the chance of trying to minimize infections. Coloplast, their device is called a Titan. Their reservoir is a bit of a different shape, same idea though. Their approach is that actually it's a very absorbent device. It'll suck up anything you put it into. So we make like a bath of antibiotics and we dunk it in there before we put the device in. It'll soak up all those antibiotics and then it'll slowly release them after it's been inserted. And the Coloplast device has a little bit more girth than the AMS ones. And the AMS ones, as you inflate them, they change in length, but the Coloplast ones do not. So there's some very slight differences between the two. And then that's what they look like. Whenever, if we're ever having this discussion in the clinic, I'll often just refer to them as the white one and the yellow one. And that's just because that's what the colors they are, and it's easier to remember as opposed to remembering the big names. Now, prior, this is actually a bit of an older slide. It used to be an uninsured service, but thankfully, with enough advocacy, some pressure, and a little bit of some media use, we were able to get this device finally insured, at least for those men who've undergone prostate cancer treatments. So it definitely is an option, and there's nothing out of pocket for you if this is something you want to have done. Now, this is one of the topics that I'm a bit passionate about, but there's some controversy in the urology world about it. It's this idea of penile rehabilitation. So it's maximizing the recovery around prostate cancer treatment. And the idea is if we can get at some of this stuff early, we could maybe have a longer lasting benefit as compared to just doing it maybe a year or two down the road. There are a lot of protocols that even suggest doing some degree of rehabilitation before even doing the surgery. Now, we don't have any good data on that at all, but it's a really interesting idea. And what does that mean? Well, that might mean, you start taking something like a daily Cialis or something before you even go in and have your surgery done. Really trying to optimize the blood flow, optimize the nerves as much as you can, and then you get your surgery and see what happens. Again, when penile rehabilitation is done properly, and really where the strongest evidence of doing this properly lies, is you get your treatment done, you come see myself or someone like me, and we start you on a protocol with injections. The injections are basically going to force you to have about 3 good, strong, rigid erections every week. You do that for about 12 weeks, right out of the gate. So you're maybe 4, 6 weeks out from surgery. You're starting this already. That's kind of the idea. And the point of it is to really force your penis to have good, strong, rigid erections, stretch it out to its full length and girth. And it's really great for length and girth preservation, which is something that, if I'm being honest, a lot of the urologic community, we kind of skim over top when we're talking about the consequences of taking the prostate out. If we don't do anything, there is going to be a little bit of some length and girth loss of the penis. How much is it? Some studies vary, but it can be anywhere between 1.5, even as much as 2 centimeters of loss over 12 months if there's absolutely no erections. So it's not something that you can just brush aside. It's real. And doing something like this immediately afterwards can help you try and preserve some of that and minimize how much loss you're actually going to have. Same goes for girth. Same idea, same principles. So lots of different ways of penile rehabilitation, and although this is not it, it still is a funny picture, as is this one, which this is actually part of a Trojan commercial, which was just fantastic. All right, so moving on to the next part would be talking about incontinence. Now, with incontinence, there's a whole bunch of different subtypes. Overflow incontinence is what we often think about when guys have a very big prostate and can't pee properly. They have this big full up bladder and they actually can't empty it. They end up just skimming off the top and they leak out all the time, and it just sort of squeaks out every little time that the kidney adds a bit more to the bladder, too much, and it just squeaks a little bit out. Urge incontinence, this is whether or not you're full or not, your bladder doesn't care. It tells you have to go right now. And to get to urge incontinence, it's basically not even asking for permission, it's just emptying. And that's kind of what urgency or urge incontinence is. Stress incontinence is what a lot of guys have after their prostate cancer surgeries, if they've had them. And that is where any laugh, cough, sneeze, pick up something heavy, stand up and walk across the room, and you leak a little bit of urine. So it's associated with the physical activity. So those are the 3 broadest types. And then you have Functional incontinence, that's a pretty specific type. That's kind of you're incontinent because you can't actually physically get to the bathroom in time. As such, maybe you're nurturing a broken hip or a joint replacement, and you just can't get there. Normally, you would be able to get there in plenty of time, but because of whatever impairment, you can't. And then mixed incontinence is just that. It's a mix of the two. And so, for example, stress and urge tend to go together quite a lot. And what happens is you get a strong urge that you need to go, but now because you have too little tone, you can't hold it back. So then you just leaks out. So you have no ability to hold it back. Then say we fix one of those problems, say I fix the stress incontinence. Well, now you have a whole bunch of urge incontinence that feels like it's new, even though it was always there. What happens? You just relieved it because you just leaked, for example. So again, overflow, this is the most common type in men. Usually large obstructing prostates are what's responsible. And you can kind of see here on the picture on the right, that's the guy with a bit of an enlarged prostate. He's almost just trying to pee uphill. It's not easy. The first group of medications we use are the bladder neck relaxers. Basically, they relax that circular part of the neck of the bladder that opens up, and just try to open it up so that you can pee a little bit better. The most common ones that a lot of guys are on is called Flomax. That's probably the most common, but there's a bunch of them in this class. One that we often forget about is actually daily Cialis has been shown to really have a positive effect here on opening up that neck of the bladder and letting a guy pee better. We forget about this guy all the time, but he works great and has less side effects than those other drugs as well. So if it wasn't for cost, he would be my go-to right off out of the gate. Then we have another group of medications that are shrinking the prostate. Avodart and Proscar are both good examples of that. It takes at least 6 months though for them to work, but they will shrink it by about 20% in 6 months. So you can get some meaningful changes. You got to be patient. And then of course there are surgeries that we do to try and open up that prostate, remove a lot of that tissue from the inside, mostly to just carve out a nice good hole for the guy to pee through. And that's what we call as a TURP procedure, or transurethral resection of prostate. We basically core out the middle, remove all of those bits of tissue, and they get sent off to the pathologist. Now, this is not a treatment for prostate cancer. This is a treatment for an enlarged prostate. It's different. This is really the gold standard of treatment when it comes to prostate cancer. To enlarged prostate treatments. There is an older surgery that we used to do. We really don't do it very much anymore. Maybe in very select cases, is something called a simple prostatectomy. This is like an open surgery where you make a cut, you get down to the prostate, and you scoop it out. Again, not what we would do for cancer. The cancer surgery is different. But this might be very good in very young men with very large prostates, because you do that TURP procedure, you leave some prostate behind. It's going to grow back, and within about 5-10 years or so, he's going to need surgery again. If they're a young, healthy guy with a big prostate, you know this is going to be a lifetime thing. You do one surgery with a simple prostatectomy, and hopefully he doesn't have to come back anymore. Now, urge incontinence, this is often secondary to overflow, but can also be complicating stress. And it can be an issue even after correcting the overflow. So I have some guys who we've done the TURP and they have a fantastic stream, but now their bladder's been somewhat dysfunctional for so many years that it doesn't really go back to normal, and it ends up being a little bit urgent that we have to sort of treat it. This can be in a very bothersome sort of situation. The main group of medications we use are anticholinergics. You may have heard of some of these drugs before. They can cause some dry mouth, they can cause some constipation, they can dry the eyes, and they are absolutely contraindicated if you have any history of glaucoma, specifically a narrow angle glaucoma, if you know. But as soon as you say glaucoma, I'm going to avoid all of these drugs. The anticholinergics kind of put a little bit of a handcuff or a brake on the bladder so it doesn't contract so much. The beta-3 agonist, different group, this medication is called Mybertriq. It works totally differently. Instead of trying to inhibit the bladder from working, it just encourages it to be more relaxed. So then it becomes a little bit more difficult for it to send you those urge signals. And then surgery-wise, one of the main things we do after is Botox. And now if you Botox the bladder and it works, that's great. It'll last for about 6 months, but then you got to come back and got to do it again. So it's an ongoing treatment within the bladder. Another surgery I don't think I listed here, there are some what we call neuromodulatory surgeries. This is where we have little devices with generators that we attach them to the nerves that are going to the bladder to try and get him to quiet down. It's a complex surgery, and I don't perform that, but one of the urologists in Saskatoon does. So we do have somebody in the province that does some of that work. So the post-prostate cancer treatment, radiation, etc., incontinence is a little different. So post-radical prostatectomy, you know, just about every guy, once the catheter comes out of the gate, is leaking. There's no way around that. Most men do pretty well in the recovery. About 10 to 20% of the men who go through radical prostatectomy are going to require more than just a liner a day. They're going through a pad, maybe two in a day, due to stress urinary incontinence. There is a couple percentage of those men who are going to have pretty bad incontinence, where they're going to get to the point where they're really going to want to do some sort of repair. Um, Unfortunately, there's a lot of men who have incontinence who do not seek help. And not related to prostate cancer, but I just saw somebody yesterday, who had just an enlarged prostate, who had a significant overflow incontinence for about 5 years and was just wearing diapers but wasn't on a single medication to help him out, just because well, it's the cost of getting old. And that doesn't have to be true. So again, many men will look at this incontinence and they'll just sort of say, well, it's the cost of cancer therapy. I got my cancer treated. I guess I got to live with this. It doesn't have to be. And that's kind of what I want to tell you. A lot of guys don't want to seem ungrateful to their surgeon. It's like, oh, it's just a little bother. Got to buy some underpants and things like that. Whatever. I don't want to insult my surgeon by suggesting they did a bad job and that's why I have leakage. We don't think that. We know that this is a risk and we know what happens. And we would want you to be better. So you're not insulting us by asking for some follow-up and treatments for some of the complications from the treatments we offer you. So what can you do? Well, conservatively, there are some things like pelvic floor physical therapy. This is transcutaneous electrical nerve stimulation, behavior modifications. Those are all options. Endoscopic, this is where we use a camera. If we think, we're trying to keep it pretty minimally invasive, we can do what's called the bulking agent. So this is kind of more for a mild leak. Basically, you're just kind of buffing up your again, just bulking up the other side of the urethra so that it's starting a little bit half squeezed, and then your muscle squeezing just pushes it the rest of the way. The problem with these is, again, they will eventually resorb and go away. So every 6 or 8 months, you do have to go back and redo the bulking. And then surgical, we have slings and sphincters, which are exactly what they sound like. So for slings and sphincters, usually the way I look at it is how many pads per day is this guy going through? Anything less than 3 pads per day, and I take a look on the inside with my camera and I ask him to squeeze and do a Kegel and I can see the muscles working well, I'm going to try and push that guy more towards a sling. Okay. What's nice about the sling is there's no moving parts. It's going to work right as soon as the guy is out of the gate. It basically provides a little bit extra closing pressure so that guy is going to be able to pee and control it. The other side is if they're going through more than 3 pads per day, or I take a look on the inside, I do that same maneuver and I say, hey, contract, you can contract now. And he's like, I am, and I'm not seeing much of anything happening. That muscle is just not going. At what point, that sphincter's toast. It's not doing anything, and we need to give you something different. And this is what this is. It's an artificial urinary sphincter. What happens is the little cuff that goes around the urethra, and there's a bunch of balloons on the inside, and they're all facing inwards. So once the cuff is activated, it gets filled with water. All of those balloons push inwards and squeeze it off like a little sphincter. And then when a guy wants to have a pee, there's that big button that you see down there in the bottom, very easy to find in the scrotum. He gets there, finds the button, gives it a push. It opens up all the fluid from around that urethra. So it just opens it up. And then all the urine that's been building up will just trickle right on out. And then it just automatically refills after about 45 seconds. So you don't have to do anything. It is just one push, empty. You stand there for about 45 seconds, and then it'll finish and slowly close up. So the male slings, they improve continence immediately. They have a very low chance of infection and erosion. but does require some basic tone. So if the guy is doing nothing, then this isn't going to do anything for him. Also, because of where they go, it is possible that a minority of men can have some hip or leg pain that could be chronic. That might stick around forever with you because of putting these devices in. It's extremely rare, but it's not zero. And you do have to tell every guy about it just in case. Now, the artificial sphincter is like I described it. It's a total continence system. You're giving up on your own physiology. We're taking it over for you. You do have to give the button a push each time. You can see there's a picture of it underneath the skin in the bottom right there, and you can see all the components of the pump in terms of where you're going to activate it. Everything. Just compare. You have the bigger portion down here, the little button there. You can see that there's the little the button right there. That's where it's being held. Because the scrotal skin is so thin, it's very easy to feel all these pieces. So it becomes very easy to use. And both of these have been around for decades. They have good long track records. So pelvic rehabilitation is initiating that pelvic floor muscle strengthening prior to the radical therapy. So some of those guys who are going in to get their surgery, well, maybe we should be sending them to the physical therapist before they even go under the knife. And then you really want to be in consult with a specialty trained pelvic floor physical therapist. Some of them will use biofeedback. Some of them I'm going to reinforce some good behaviors immediately in post condition therapy for conditioning. And one part we often forget about is, particularly in medicine in Canada, all of these things are covered, but what's not covered? Well, how many diapers you're going through. And as a result, studies have suggested that the incontinence component has a lower quality of life than to something like dialysis, which we all know has a pretty limited quality of life. So not to ignore the fact that this can be having a really significant impact, and trying to correct and fix it might be really worthwhile to do for you. So, last time I was in the shoppers, I kind of went by and just quickly said, well, what is this gonna cost to be incontinent? So a 14 pack of the Tenna was about $27, about $1.92 a pair. If I only use one a day, well, you're gonna be spending about 700, close to just a little over $700 a year just in incontinence pads. And for those who are more environmentally conscious, I'm not even talking about the amount of garbage and waste that you're generating. That's a whole other conversation. But this is one pad a day. If you can imagine, there are some men who are using 2, 3, 4 pads a day. They're spending $1,400, $1,500 or more just on stuff they're going to throw out. So there definitely is a cost to the incontinence here that it's worthwhile exploring. Now, I think, oh yeah, the environmental costs, I did mention that already. All right, so now there are some new slides here. This is where it gets a little spicy, okay? This is where, certainly if there are any other healthcare workers who might be watching this later, this is where there's definitely some controversy here. This is a clinical case, it's a little scenario. 63-year-old guy, low energy, fatigue, no erections, low desire, difficulty concentrating at work. It's been ongoing for about 3 years. You check his testosterone levels, and you guys won't know this, but those are both pretty low testosterone levels. So it definitely looks like he has low testosterone. But on his history, you see, this guy had I didn't put a time in here, but let's say 5 years ago, he had his prostate out. He had Gleason 7 prostate cancer. Margins were negative, nodes were negative. All of his follow-ups been negative. But he has that prostate cancer history. Now, classical teaching was absolutely not. You don't mess with this. Any previous diagnosis of prostate cancer means testosterone's off the table for life. That's not really the belief anymore. Things have changed. So just to give a little bit of a brief background here, and I apologize that I don't have this with more reference data and studies for all of this. I kind of was fairly busy today, and I wasn't able to pull everything together. So we're going off kind of my memory here a little bit. But this whole concept of testosterone and prostate cancer was born to be from Dr. Charlie Huggins in the 40s. He had a great paper that he put together. He and a couple other authors. This is based out of Johns Hopkins. Interesting trivia. He's actually a Haligonian. He's actually from Nova Scotia, and then went down and practiced in Johns Hopkins. And then he identified that prostate cancer was sensitive to hormones, both positively and negatively. And at that point, he came up with the beginning of the dogma that giving testosterone to a prostate cancer patient is like throwing gas on the fire. One of the patients that he reported on basically did that. He had taken away that guy's testicles, and then he saw what happened. He gave him testosterone back, and that exploded in mets everywhere. Now, this dogma persisted for like 70 or more years. This was the 40s, and it wasn't until easily into the early 2000s, 2010s, did anybody ever think to challenge this. And the reason it got challenged is because they went back to that original study and actually read it again. And what they realized is that all of those conclusions were based on Dr. Huggins looking and evaluating a single patient. It wasn't a case series. It wasn't 5, it wasn't 10, it wasn't 20 patients. It was one. Now, he was right in that if you take away testosterone, you can starve of prostate cancer. We've been using that for decades. But just basing, the non-use of testosterone in prostate cancer based only on a single patient from 1939, 1940 is a little wild. And these two doctors, Dr. Kerr and Dr. Morgentaler, were the first to kind of really start to challenge it because they went back, saw that original study, and went, "Wait a minute, this doesn't really hold water." So they started doing some studies, and you'll see those names on here a couple of times. What they did is they started giving guys who were symptomatic, so this is low testosterone, and they had the symptoms and they had the biochemistry. They started giving them testosterone back. So the first group, again, it's just small, 57 guys. They only followed them for a year. I'd argue you should follow them for longer, but it's a start. And none of them recurred. They did well. These are guys, they had their prostate out, margins negative, everything's negative, and they looked good. That's impressive. Next group's a little longer. This was in 2013. This is EBRT, is external beam radiation therapy. Only 16, so it's a really tiny study. But 29 months is a little bit better follow-up. Again, no evidence of early recurrence or a change in recurrence because they gave this guy testosterone. Morgentaler, again, he did another one. This is really where it gets spicy. This is in 2011. This is men on active surveillance. So just to think about that, we haven't really talked about the different treatments for prostate cancer, but one of them, if you have a very low grade cancer, is what we call active surveillance. This is an untreated low grade cancer that this fellow was giving testosterone to these patients and noticed no change or acceleration in their PSA, their prostate cancer, redid some biopsies, nothing changed. They just continued on doing what they were doing, except they felt better because their low testosterone got treated. Again, it's only 2.5 years, roughly, of how long they followed them up. Not a huge long follow-up, but still pretty good. And then this last one is particularly for, if there's any urologists in the room, is going to blow some minds because was high-risk guys. These are ones who had more aggressive cancers. That's Gleason 8 cancers. They may have had a positive lymph node, or they had a single positive margin. And again, it's a small group, well, it's only 26, but they watched them for 3 years, and they did not notice any differences in recurrence rates between those who they treated and those who they did not. Now, I always say this, let's not get ahead of ourselves. I'm not saying it's 100% safe and that just throw the testosterone everywhere. These are all very small studies. They're all very underpowered. It's difficult to make any strong conclusions except for it's worth a careful discussion with the patient about whether or not this is something that they want to proceed with, especially depending on how much a low testosterone diagnosis might be impacting their lives. So in general, TRT or testosterone replacement therapy would be considered kind of contraindicated with the active history of prostate cancer. However, the amended statement I often will put to this is that with proper patient selection, adequate informed consent of the risks, close monitoring, testosterone replacement therapy could be attempted in the right patient, carefully selected again, with some very, very close monitoring. And I certainly have a good number of guys that I've done this with. I think of all of the guys that I've replaced either after treatment or some guys even on active surveillance, and I've done that. I'm not even sure how many I have, at least 50 or 60 or if not more. I've only had one guy who looks like he had some recurrence of this cancer. And the way I sort of talked to him about it is that it wasn't so much that the testosterone caused it, it's just the testosterone unmasked what was there. And I have this conversation a lot with guys when they're starting testosterone therapies, but if they're symptomatic, they're very worried about prostate cancer risk. And again, the testosterone doesn't cause the cancer, but if there is one there, it will unmask it. So it's a separate signal to have the cancer than the testosterone. Testosterone is an important fuel, and it is required during growth and development to open the door for you to get a prostate cancer. But having more doesn't make it more likely to happen. And there was a very recent study that came out, I think a year ago, maybe less, that actually very definitively put this to bed now. That looked at guys who had testosterone replacement, looked at their rates of prostate cancer, and there is no difference. And in fact, one of the interesting things that we've seen about prostate cancer and low testosterone is that in guys who are diagnosed with prostate cancers, if they were also diagnosed with the low testosterone at around the same time or at the same time, or they had a known untreated low testosterone and then they had a cancer diagnosis, they are more likely to have a more aggressive cancer than the guy who had normal testosterone and who got that same diagnosis. So just that simple fact, which we've actually known for some while before we started pushing this envelope, really flies in the face of testosterone causing cancer. Because if it did, those guys with the low testosterone should be protected, but they aren't. In fact, they tend to have worse disease when they get it. So it doesn't really fit together. All right.